Hi guys, this is Joel. Today we're talking about weakness. So if someone presents you weakness, it can mean a whole bunch of problems. So our nervous system consists of our brain, the subcortical region, the brainstem, spinal cord, and below it we have our peripheral nerves, and then we have a neuromuscular junction, and finally we connect to our muscles. Right, so if any part of this gets damaged, we're going to have muscle weakness. So the first thing that we're going to ask our patient is the onset. So the onset of weakness can be divided into acute, subacute, and chronic causes. Especially acute, we have broad vascular causes, such as ischemic stroke, or in infections like meningitis, toxoplasmosis, or poliomyelitis. These are just some of the examples of infections. And sometimes we can have metabolic causes, such as hyperthyroidism, Addison disease, Cushing syndrome. But take note that metabolic causes can be variable, which means they can either be acute or chronic. And other examples of variable weakness is toxins, like mercury, lead, and of course we can also think about hemorrhage or any traumas. Now moving on to subacute causes, it's usually caused by inflammation. Inflammation is also called as myositis, right? So we can have a lot of examples for myositis, including polymyositis, dermatomyositis, inclusion body myositis, or even SLE, rheumatoid arthritis. Alright, now our chronic causes, as always, tumors, or some space-occupying lesions, such as normal pressure hydrocephalus, which means our ventricles are filled abnormally with too much cerebral spinal fluid, or it can be degenerative disease, such as Parkinson's, Alzheimer's, which can happen over time as people get old, or it can also be due to long-standing hypertension or diabetes mellitus. Hypertension can cause white matter degeneration, and diabetes mellitus can cause peripheral neuropathy. Sometimes you should also think of autoimmune chronic degenerative disorders such as Guillain-Barré. Autoimmune, such as Guillain-Barré, multiple sclerosis. Although multiple sclerosis happens in attacks, but Guillain-Barré is more towards degenerative. Sometimes myasthenia gravis can also occur in chronic. And of course, alcoholism. Alcoholism actually causes alcoholic amyotrophy. Okay, so one thing I forgot to mention right here is acute is usually ranging from hours to days. Let's just say 7 days. Subacute usually range from days to weeks. And chronic is usually calculated in months. Now the second question that we're going to ask our patient is the distribution. So talking about distribution, there can be a few, such as hemiparesis. Paresis means partial paralysis or weakness, or we can have paraparesis. Paraparesis means both legs are weak. Hemiparesis means one side of the body weak. Or we can have monoparesis. It means one limb. Or we can have quadriparesis. It means all 4 limbs are weak. And sometimes we can classify the distribution based on the pattern, proximal weakness, okay? Which means the weakness starts from the trunk, starts from the body trunk. And we can have distal weakness, which means the weakness starts from the foot or for the feet and moving outwards. So before I go into the details of each distribution type, I would like to explain the mechanism that's causing this kind of distribution in our body. And the best way to explain it is by looking at our anatomy and our motor tracts. So just to let you know, hemiparesis is always caused by our motor neuron lesion. For example, our corticospinal tract. Now, our corticospinal tract is the tract that controls voluntary movement below the neck area. So I would like you to note that our cranial spinal tract actually travels down at one side of the brain, and then it decussates at the medulla pyramid, and then further travels down the lateral column of the spinal cord. See, this is the lateral white matter column of the spinal cord. And then it connects with the third order neuron this third order neuron is the lower motor neuron and connects to our skeletal muscle. Now the difference here is, if the lesion occurs in the motor cortex, then we're gonna get contralateral hemiparesis because the fibrous decussates. So let's say this is the right side of the brain is damaged, then the left side of the body is gonna get affected. Now, if the lesion occurs somewhere below the level of medulla, let's say, or it occurs in the medulla, a medullary pyramid, then we're gonna get ipsilateral, our upper motor neuron in the brain and spinal cord. Wherever there's lesion, it's gonna be hypertonia, hyperreflexia, and then we're gonna get spastic paralysis. This is because as our upper motor neuron is damaged, we're also damaging all the inhibitory neurons that controls the muscle tone of our muscles. So let's say there are inhibitory neurons all the way from the brain to down here. So if the upper motor neuron is damaged, the inhibitory neurons are damaged altogether. So there'll be no inhibition, and sometimes we're gonna get clonus, which means repetitive movement of the muscle, and positive Babinski sign. Another type of paralysis is the flaccid paralysis, which means it occurs in the lower motor neuron. So LMN lesion cause flaccid paralysis because the inhibitory neurons are not affected. So paraparesis means both legs are weak. Now let's say one level of our spinal cord is damaged. It can be due to infections, causing abscess, or it can be due to trauma, causing lesion or hematomas, or it can be due to autoimmune transverse myelitis, or sometimes can simply because the intervertebral disc is pushing forward or prolapse forward and compressing on the spinal cord or the nerve roots, or some degenerative disc disease causing the vertebrae to fuse together and actually causing compression to our spinal cord. So now if the transverse myelitis actually occurs at the lumbar region, let's say this is L1, then only our legs are gonna get affected. But if the lesion occurs at the cervical area, all the areas below it will get damaged. Therefore, we're gonna get quadriplegia, which means all four limbs are paralyzed. Now we've talked about hemiparesis, para, and quadri. How about monoparesis? So for monoparesis, it is usually due to the peripheral nerve damage. So that either going to be peripheral nerve is damaged or the nerve root is damaged. So the nerve root can be damaged due to the degenerative disc disease causing the vertebrae to actually compress on the nerve roots. And for this disease, we call it radiculopathy. And for peripheral nerve of only one limb to get affected, usually it's gonna be caused by trauma. Because there are a lot of other diseases that can cause peripheral nerve disease, but they usually affect more than one limb. So now we talk about monoparesis. Let's talk about proximal and distal weaknesses. Now, in order to understand proximal and distal weakness, there are some rules that I want you to understand. Proximal weakness means the muscle in our shoulder girdle or the arm or the proximal arm or the pelvic girdle or the thighs are going to get affected. And then this weakness usually moves downwards, so we call it descending weakness. But distal muscle usually affect the muscles most distal to our body first, usually from the leg first and then gradually moves up. And we call it ascending weakness. And ascending weakness is usually caused by peripheral neuropathy. And descending weakness is usually caused by myopathy, which means the muscles are affected. Now I want you to think, all the nerves in our body has different lengths. So for the nerve that supplies our feet is usually going to be the longest. So the signals have the greatest difficulty of reaching them, so making them most susceptible to any damages. Therefore, in peripheral neuropathy, such as Guillain-Barré syndrome or some diabetic neuropathy, usually both legs are going to get affected first. And then for our descending weakness, the muscles, let's just write it here, the muscles in our pelvic region or shoulder girdle region are the biggest. So they're going to need a lot of energy compared to other muscles in our body. That is why in some diseases like myasthenia gravis, so this is the neuromuscular junction. In myasthenia gravis, there will be antibodies that binds to the muscle receptors, so causing the acetylcholine unable to bind to them. So when those muscles doesn't receive enough stimulation, they're going to have weakness. And another problem is muscular dystrophies. So by this I mean some of the common ones is Duchenne or Becker muscular dystrophies. Now Duchenne and Becker are usually caused by a protein deficiency known as dystrophin. Now if you look at this picture, dystrophin is actually a protein that is binding to the sarcolemma, this layer, the outer layer of the muscle, and the muscle cells. So it kind of stabilizes the muscle fibers. So without this dystrophin, the sarcolemma is going to become floppy, and it's very susceptible to any damage to it. The sarcolemma actually creates a hole inside it, and then causing the calcium to enter. And then when the muscle cells damage, it actually releases creatine kinase. So this calcium cells that enter can cause apoptosis of the muscle. So again, the muscle in the pelvic region, the largest muscles are going to get affected first because dystrophin is present in most abundant in the pelvic region and the largest muscles. So other myopathies such as inflammatory myopathy known as myositis, such as dermatomyositis or polymyositis or occlusion body myositis, it's also an autoimmune condition that damages the muscles. So whatever affecting the muscles, we're going to think of proximal muscles first. Now how about the symptoms? In proximal muscle weakness, you're going to have problems standing up or climbing stairs, or do whatever things that requires to use your thigh muscles. So when you're walking, you're going to have waddling gait. It means the person's going to waddle like a duck. You can look up the video online and see how the duck walk. And then when they're standing out there, there's going to be a sign called Gower's sign, where they stand up. They have to stand up with the help of their hands. And you can actually online see this, how Gower's sign looks like. And for distal, you're going to have a problem known as foot drop. This cannot plant her flex. So when you're walking, it actually creates a gait known as slapping gait or high stepping gait. And then if the muscle affects your arms or your hands, then you can have problems opening jars or riding, anything that involves the use of your hand muscle. But there are one thing that I forgot to mention just now under quadriparesis is metabolic disorders. So these metabolic disorders actually includes endocrine causes such as hyperthyroidism, hypothyroidism, hypercortisolism, also known as Cushing syndrome, hypocortisolism, also known as adrenal insufficiency, or in other words, Addison's disease, or sometimes it can be a hypercalcemia, or hyperkalemia, or hypokalemia, or sometimes it can be hypernatremia, causing all these metabolic disorders. Now, this is going to be a little scary, but I'm going to explain one by one the mechanism. So, hyperthyroidism, as we know, thyroid hormone increases metabolic rate. Therefore, our muscle breakdown is going to be increased as well, therefore causing muscle weakness. By hypothyroidism, due to decreased metabolic rate, the muscles that are broken down cannot be restored or repaired. So this hypercortisolism, cortisol has a function in protein breakdown. Therefore, if cortisol is too high, our muscle is going to be break down too fast. Adrenal insufficiency, cortisol also has another function, which is to retain glucose in the body. So low glucose level in the body is going to make our muscle to receive insufficient nutrients, and this can also lead to muscle weakness. Now for hypercalcemia, we have to look at the intracellular and extracellular ions. Calcium is an extracellular ion, and potassium is intracellular, and sodium is extracellular. They're mostly extracellular, and potassium is mostly intracellular. So hence they created membrane potential. That's going to be like this: negative, negative, positive, 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 positive. Now, if a calcium is somehow increased too much, maybe due to hyperparathyroidism, or increased bone breakdown, or increased oral intake, or whatever, this is going to make the outside even more positive. This is our resting membrane potential. If the extracellular is going to be more positive, then it's going to make our resting membrane potential even lower, which means in order for it to pass the threshold, it's going to be harder. It has less excitability, to say. So the same thing applies for sodium. If the sodium increases, it can be more positive. Or sometimes if the K plus increases, it's also going to be more positive. So whatever these ions increases, it's going to decrease the excitability of the cell. Now, how about hypokalemia? Hypokalemia is a different story. It means we're going to get less K plus out here. So that means instead of being positive, 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 we're going to become positive, negative, negative, negative. This time, our resting membrane potential actually increases. So at first, it might seem to increase excitability, but then the increase of this resting membrane potential actually causes the sodium channel to close. Therefore, it decreases excitability again. In some people, it is a genetic condition. They're going to have hypokalemic periodic paralysis, which means their body has an innate defect in the transport of potassium, causing hypokalemia in the body, and sometimes they're going to have attacks of weakness of this quadriparesis. Now, other than all the things that we talk right here, there's also another thing that we can examine our patient, is if that muscle weakness is symmetrical or not. So most muscle weakness are going to be symmetrical, except for a few, such as myasthenia gravis or any inflammatory myositis, or multiple sclerosis. So just to recap for everything that we talked about just now, for hemiparesis, it's going to be upper motor neuron lesion. For paraparesis, it's going to be transverse myelitis or any spinal cord lesions that is below the lumbar area. Now for quadriparesis, it's going to be spinal cord lesions that's happened at the cervical cord. And then for motor paresis, it's either be peripheral nerve, or it can be nerve root compression, known as radiculopathy. And quadriparesis involving other metabolic disorders, spinal cord. Oh yeah, one more metabolic disorders, vitamin B12 deficiency. Because vitamin B12 actually is involved in the DNA synthesis, so it's going to affect the muscle synthesis. Now sometimes alcohol can also cause alcoholic amyotrophy. This is because alcohol actually causes direct toxic effect to our nerve. And for proximal weakness, it's going to be muscle. So it's going to be myositis, such as poly or dermatome, or inclusion body myositis, or it's going to be myasthenia gravis, or it can be any muscular dystrophies. And for distal weaknesses, we're going to have peripheral neuropathy, such as Guillain-Barré or multiple sclerosis. There's also another thing called myotonic neuropathy, which means the muscle myotonic basically means it's affecting the muscle tone. And in this case, we're saying hypertonia. The muscle is unable to relax after contracting. And this can usually happen in the hand, but the patient is unable to relax the grip after. So as usual, I'm going to cover a little bit about the investigations. Of course, the first thing that we can do if you suspect it is an acute weakness is we're going to give CT scan of the brain to see if there's any infarct or hemorrhage or any tumors. Or sometimes you can see other space-occupying lesions such as normal pressure, hydrocephalus. Or if you suspect the spinal cord damage or spinal cord lesion, we can give it a CT scan as more or the MRI of spine to see if there are any vertebral column or spinal cord or nerve root compression. And if you suspect if it is a muscle, if it is a neuromuscular junction with muscle weakness, such as myasthenia gravis, we can do creatine kinase, serum creatine kinase, to see if it's elevated in muscle damage. Or we can do a nerve conduction test to test for any peripheral nerve damage. Or we can also do an EMG, known as electromyography, where we actually put a probe on the muscle to see, like an ECG, but in this case we see the electrical signal of the muscles, see if it's normal. Or sometimes we can be more specific, like we test the autoantibodies in the body to confirm any autoantibody disease. Or sometimes we can test dystrophin level in the body, or we can use a thing called Western blot to actually see the pattern of increased dystrophin in the body. Or if you suspect if it's an endocrine disorder, then we can do the serum hormone test. And of course, don't forget if there's diabetes mellitus or high hypertension, we can always do a blood glucose level test. Blood glucose level or blood pressure monitoring for any underlying comorbidities. And for the treatment in this video, I'm not going to go into very detail, but generally, if there's any infarct or any vascular causes, we usually give embolism or any fibrinolytic. And for metabolic, we usually correct the hormone or electrolytes in the body. And if it's a DM, diabetes mellitus type 2, we usually just give correct the blood sugar level. But if it is auto, so guys, that's basically most of the things I want to tell you today. Although there are still a lot of causes that I haven't covered in this video yet, these are some of the more common ones. So I hope you understand what I taught you today. And if you think I missed anything important and I said something wrong in this video, please just comment down in the comment section below so we can all learn together. And with that, I'll end my video right here. And my school is reopening soon, so I don't know if I still keep making videos, but as always, we'll see you again. Bye.